Hello, everyone, and welcome. My name is Shamira Foster, and I am with the Aurora African American Health Coalition. Um, First, I'll ask that if you have any questions, just put it in our Q&A section, and Dr. Trask will answer them at the end of the presentation. This workshop today is part of our Black History Month series and will be led by Dr. Jeffrey Trask. Dr. Trask will be sharing information on increasing cultural competencies in healthcare providers. Dr. Trask has been a healthcare professional in various capacities for the past 28 years, working in hospitals, public health, free clinics, and school-based clinic settings. Additionally, Dr. Trask has taught in higher education on a multitude of healthcare topics for 20 years. In addition to his healthcare experience and education, Dr. Trask is highly involved in racial justice and being part of multiple reparations organizations, establishing DEI roles in academic institutions and educating the public about racial inequities, such as in healthcare. Now I will turn it over to you, Dr. Trask.
Thank you for the wonderful introduction and welcome everyone this afternoon. I have a lot of things I'd like to cover, so I'll jump right in and I'll look forward to having a good, robust Q&A afterwards as well. And so today we're going to talk about how history and the present matter. And this is one of the ways we can enhance our cultural awareness and sensitivity. And these things are important because we know there's lots of different healthcare disparities and issues among African Americans and other racial groups. We'll go through some of that, starting with the history and working into present day inequities, and then how we could go about trying to close those gaps. I already had the introduction, so I won't bother with this at all, but you can always reference this later on. And I'd like to start off with a quick story. One day, this kid named Diggory, he's 4 years old, and he went to his dad and he says, Dad, I dropped my toothbrush in the toilet. And so Diggory's dad gets out of bed, goes over to the bathroom, fishes the toothbrush out the toilet, and throws the toothbrush away. And all of a sudden, Diggory takes his dad's toothbrush. He throws that in the trash, throws that in the trash can too. And Diggory's dad's like, "Hey, Diggory, why'd you throw my toothbrush in the trash can?" And Diggory says, "Well, your toothbrush fell in the toilet 2 weeks ago, so I figure I'll throw that one away as well." And I always love to share that story because I always want to pose the question: is ignorance truly bliss? Right. And when it comes to any type of learning of new information, the answer to that question is typically no. We don't want to be brushing our teeth with toothbrushes that have been in the toilet for 2 weeks. And so, with that in mind, I want to talk about history and why it matters. And it comes to how we take care of patients in an equitable and culturally competent fashion. A lot of us are not fully informed about, for example, the past and history that African Americans have experienced from the time they were kidnapped from Africa to today. There's lots of misinformation. There's a lot of lack of information. I know personally when I grew up in school, there was like a paragraph about slavery, how you can encompass hundreds of years of a practice into a paragraph in school. I have no idea. Today we have controversy or even learn about African American history with critical race theory. And one of the things I want to even highlight right from the very beginning, because I do think this has an important part to play when it comes to healthcare, is how we view Black people. And even historically, we often use the term slave, and that term doesn't really have any kind of humanity attached to it. Do we think of the word slave, when we think about that word itself, do we think about people, fully human, individuals? Um, and if so, we shouldn't use the word slave. We should be referring to people as enslaved persons or people or individuals. Because after all, each of these individuals who were enslaved had their own story. They had their own family and family network. We think about those who were kidnapped in Africa. They weren't slaves in Africa, enslaved people in Africa. They were free people who, had communities, had roles to play in their communities. In today's analogy would be folks who were lawyers and doctors and dentists and everything else, and all of a sudden people just start snatching folks away. So we got to just kind of keep that in mind that this whole group of people started off and it was always people, not slaves, enslaved people. And so we want to think about that history. I'm just going to throw out this book here, and you might have heard of it, but it's one of the best books that kind of highlights all the different ways that African Americans over history have been not treated fairly, equally, equally, particularly in various healthcare environments, whether it be experimentation, whether it be studies like the Tuskegee experiment, and so on and so forth, and so on, a whole bunch of number of things. I apologize for the color on this slide, but basically just highlights some of the things that's in her book. All right, so I want to talk real quickly about some of the going back to days of slavery, and again, some people may say, "Well, way back when, what does that matter now?" You'll see that the reality is that how African Americans are treated as a people from way back when does still have indeed an effect right now, um, and I'll give you the examples of that in our Q&A as well. But in any case, one term that Joyce DeGruy talks about is post-traumatic slave syndrome, this idea that enslaved people had to experience all types of torture, working from sun up to sundown, all types of disparities and whipping and all kinds of stuff that happened to them, rape, separation of families, and no one got any kind of mental health treatment, right? So we have this whole history of all this trauma and taking place among a whole group of people with no history of it ever being addressed at all. We think about our current soldiers, for example, that have post-traumatic stress syndrome and how much we try to account for the things that they're trying to adjust to and deal with from their experiences. We didn't have anything like that for enslaved people after the war, or even anything after that. I also want to briefly talk about some of the diseases of the slave, according to the current advanced medical information at the time. Because one of the things we want to keep in mind is the things that I'm going to talk about were things that were cutting edge, right? We think about what are the most advanced medical scientific studies today, and we take that as gospel to move forward because we want to make sure we're doing the most advanced types of procedures and so on and so forth. Well, I'm going to give you information about what the most medical advanced people of their day was saying and how that had an effect on people. Well, I'll briefly talk about the conditions on plantation because there are misconceptions that things weren't as bad for slaves as people sometimes make it out to be, as if they weren't that bad off in their enslaved type of a situation there. So we'll talk about that, and then just in general what slavery as an institution meant to this country and how it was so embedded and why it matters. Now, I do a lot of work when it comes to reparations and things of that nature. And one of the things I wanted to highlight is, if you ever hear people talk about reparations, why would they be talking about it? Well, first off, you got to realize that, again, this all started with the practice of slavery. And well, why was slavery so important? We're talking about something that happened from literally the quote unquote discovery of the new land, North America, all the way until 1865. That's a span of 246 years of this country being able to take advantage of free labor. And so imagine if you had a grocery store and I had a grocery store down the street from you, and you had to pay your employees. And then usually for any type of business, your employee costs, labor costs are going to be about 65% of your costs. It's usually the biggest cost you have as any company. But meanwhile, down the street, I'm not paying my employees. My employees come in and work full time for free, right? And so what would I be able to do with my prices compared to you? Well, obviously, if I'm not paying 65% of costs, I'd be able to drastically reduce my prices of my groceries. And what does that do for you? Well, needless to say, you probably won't be in business very long. And this is basically the environment that the United States was in because due to slavery, they were able to produce and sell, deliver cotton all over the world cheaper than everybody else and pretty much ran other cotton producers out of business by the 1830s. Cotton became the dominant driver of U.S. economic growth, so much so that it went from 14% of exports, money coming in from exports in 1802, to 42% between 1820. And then by the time we got to 1860, over half of the money that the United States was receiving, I believe it was like 53%, came strictly from sales from cotton. It's almost like, when Saudi Arabia has 75% of oil reserves, well, imagine if they had 100% of the oil reserves. They're already a rich country. Imagine how rich they'd be if they had, all the oil. Well, this was the United States situation when it came to cotton in America. They was able to build their financial portfolio that made the United States the biggest, wealthiest country on the planet. And which is another thing, people will never argue that the United States is the wealthiest country in the world. We spend $5.3 trillion in healthcare alone. But people don't often ask the question, well, how did it become the most wealthiest country in the world? Because after all, it started in 1776 as a nation, And 84 years later, it found itself as the number two economic power in the world, only behind Great Britain. How did that happen? Well, it happened because of the slave trade. I mean, there is countries that have been around for 4,000 years, and yet we were able to surpass them in a matter of 84 years. So I want to talk a little bit about diseases of slaves. And the reason why I want to talk about this is because, again, we're talking about what the current culture believed was true and the most advanced ways of thinking about medical care. And so in 1851, and I won't begin to know exactly how to pronounce these diseases, but let's call it draperotomania. But basically, it was this idea that enslaved people were diseased if they wished to escape, right? And so it wasn't that enslaved people want to escape because of the lack of freedom and all the other torture and things they have to deal with, but they actually had a diagnosable disease if they wanted to run away. And what was fascinating about this also was that this disease was caused when slave masters treated their slaves, quote unquote slaves, too much like equals. Actually, supposedly treated more like people, then that was more a reason why they would want to run away. So, in addition to that disease, they also had this feeling that was other types of diseases they came up with when the solution to these diseases in some cases was, as Cartwright mentioned here, whipping the devil out of them. And that was as a preventive measure to keep them from wanting to run away there. And so the solution, the cause of the disease was treating black people like people. The solution to the disease was preemptively whipping them. There's also a theory about why enslaved people were quote unquote lazy, was characterized by partial insensitivity of the skin, and so a great heptitude or mental lethargy of the intellectual faculties as to be like a person half asleep. And so, in other words, they literally tried to diagnose this idea that African Americans, black people, were lazy by nature. And again, the solution to waking up people with this was to stimulate their skin through the practice of whipping them. And even goes so far to say that and this is the leading doctor at the time, goes far to say that the enslaved person will be grateful to the white person that they're waking them up out of this kind of cloud-like state by whipping them. And again, just want to note how this was the modern medical thought at the time. And I find it highly fascinating with this laziness piece too. Very think about this idea of laziness and anything we remember, seeing in media and culture about the glorified South is usually a enslaved person in a cotton field with a white person on the porch drinking lemonade. So I find it fascinating that black people were considered the lazy ones there. There's other slave diseases out there as well. One in particular literally justified the raping of black women. It was basically this idea that the black woman was too voluptuous to be not raped. And so they literally gave a pass to white men for raping black women, not due to their problems, but due to black women being too attractive not to resist there, basically. And you think about this idea, this voluptuousness idea is not a thing that has disappeared over the years. If you watch movies that feature anywhere from Tyler Perry or Eddie Murphy or Eddie Murphy, Martin Lawrence, all these movies at some point in time, these actors feature themselves as these over voluptuous black women. So that same stereotype imagery is very prevalent even today in today's media. And, another thing I'll just note real quickly, there's a Netflix documentary by Jeffrey Robinson that talked about how the average African American has about 20% of white genes in their blood, and that's not due to all the, positive relationships black people had with white people. It was due to the raping of black women over the years. All right. The actual diseases of enslaved people was pretty extreme. In those days, if you know anything about healthcare wasn't any good for the most part until about the 1920s and 30s. 1920s, healthcare was so bad that hospitals were called death houses because it was a place you went to die, not to get better. Surgeons were were basically doing brain surgery without washing their hands. They use the same sponge to clean an infected person, sore from one person to the next. They actually believe that big rooms with no ventilation and a bunch of people in it was the best way to house folks when it comes to healthcare, which again is complete opposite. Thanks to Florence Nightingale that enlightened the practices at the time. So healthcare wasn't that good. Needless to say, there's a lot of things we didn't know, but it included real disease included things like smallpox, whooping cough, tetanus, syphilis, leprosy. The list goes on and on. And of course, high for mortality, which is something that I'll highlight that we still deal with even today. So while working on plantations, many enslaved people face serious health problems, improper nutrition, unsanitary living conditions, excessive labor made them more susceptible to diseases than their owners, and the death rates among the enslaved people were significantly higher due to diseases. And we think about all the physical harm and diseases that were prevalent among enslaved people, but you also have a host of mental health things that will obviously arise in those conditions. And again, we're talking about people. When we think about this notion of the quote slave, we don't really connect the dots and say actual people went through this stuff, and any person who goes through this type of trauma is going to have some major health, mental health, and physical health problems. We're talking about bodily abuse, verbal abuse, sexual abuse, stress, separation of your families, the outlawing of education, where you literally could be killed or get in a lot of trouble if you knew how to read. And you think about some of the things that carry on to today when you talk about some of the issues that we have in African American communities and lack of education. We're talking about a group of people who started off being in this country being threatened for death, threatened with death if they knew how to read. And then, of course, we have the taboo nature of mental illness that has transpired over the years. And again, keep in mind that you can't find a single case, a single example or case study or anything where any enslaved person got any kind of treatment for all that mental health, uh, those mental health issues there. And again, why does it matter today? Well, we know there's lots of things that we're finding out epigenetically that get transferred from generation to generation. There have been some studies that show how stress can linger. You have this one study that was done with the descendants of Holocaust survivors who had a higher likelihood of stress disorders compared to the children and grandchildren of Jewish people who lived outside of Europe during World War II. So again, Holocaust survivors, their kids and grandkids have more issues than those who weren't in the concentration camps. They also did some studies with mice and how they trained mice to fear the smell of cherry blossoms. And then those offspring exhibited the same fear of those cherry blossoms, even though they were just born to the mice that were originally, trained to be afraid of it. Again, we can see this generational effect of things happening from one generation to the next. uh, Talking about the Civil War. They're showing that sons of Civil War veterans who had been prisoners during the war had shorter lifespans than sons of soldiers who fought in the war but had not been taken prisoner. And so, in any event, if you think that some of these stress factors and genetic changes disappear over time, there's also the ripple effects. So even if it does disappear, you still have the damage that was caused by all these things I've been talking about. So while the stress of slavery eventually dissipated, you also had new stressors that came up as well: Jim Crow, structural racism, Ku Klux Klan, so on and so forth. All right, so we finally got to a point where Black people became full people when it comes to being, not being enslaved, but healthcare still didn't match that at the time. Um, I won't go into the history of healthcare during the Great Depression, but healthcare, as it did get better and improved, um, it was able to actually start taking care of people and saving people's lives, and advances went on. Medical schools became more accredited and considered standardized, and so on and so forth. So things got better in that regards. Um, but you had this situation where African Americans still face major disparities, disproportionate rates of access to healthcare, disproportionate rates of access to medical care. That still was something that was very prevalent due to racism and so on, and discrimination, so on and so forth there. And also, just a quick note, um, for healthcare historians, healthcare obviously has been tied to our employment since the very beginning. Unlike every other country that has found some form or fashion of nationalized healthcare, whether through insurance or through direct hospital care, we have a situation in the United States where it's based off of market-driven systems, and so a lot of healthcare is based off of one's employment. Well, again, historically and even today, African American unemployment rates are always been higher, and therefore you're going to have higher rates of uninsurance due to that lack of less unemployment there. I won't go into a lot of details with some of these examples, but you've all heard of Tuskegee experiment that went on for decades, from 1930s to 1972, even though in 1940s they came out with a cure for syphilis. And again, think about the system. And I want to kind of keep reiterating this. It's the system that was in place that caused this tragedy to happen, but also was prevalent across the country. We always highlight these kind of things because they're so well known, but this type of socialized, constructed lack of access was prevalent across the country, or the abuse and use of Black people was prevalent across the country. With the Tuskegee experiment, it's just such an extreme case because it lasted for so long when these men who slowly died of syphilis, which again is one of the worst ways to die, in terms of just stretching it out. They could have been cured, the whole time. And at the end of the day, there wasn't a whole lot of justice. Bill Clinton finally apologized for it in 1995, 23 years after it ended. And then there wasn't very much money to the families that were descendants of those who were victims. Some of you might have heard of HeLa cells, Henrietta Lacks. Another tragic story in terms of doctors taking her cells and being able to use those cells to do studies and research that ultimately was used all across the world. And meanwhile, while her cells were used by scientific laboratories and hospitals all across the world, her family were still left with not even being able to afford health insurance themselves. There was no consent at all given for the use of her cells, and even the family was surprised about how much their family members' legacy was being utilized everywhere. A little more modern incident happened. There was a case where um, there's these doctors, surgeons actually, that were using this practice of arterial leg stents, overly using them to a point of where they will be able to charge $10,000 per patient for this procedure, making as much as $100,000 a day doing these procedures. The problem was is that they basically, Black folks who were targeted for this didn't need the procedure by and large. And it was basically just being utilized because there's a high reimbursement for it. And people took advantage. They even recruited Black folks at churches and so on and so forth to get these low income African American elderly people to get this procedure done there. And this was getting recent, happened around right before COVID, 2018. Speaking of COVID, as we know, there's lots of disparities in that. We look at Chicago's population that has 32% African American, but over 60% represented 60% of the COVID deaths. Even more extreme in Milwaukee, where African Americans make up 27% of the population and had 73% of the COVID deaths. We also have prisons with disproportionate number of African Americans, and therefore was disproportionately affected by COVID as well. I can get into the whole mass incarceration conversation all day long as well. People do not get proper health care in prison systems, and Black people are well overrepresented in the prison system, despite the fact that the vast majority of prisoners are in prison based on drug-related crimes and penalties. Um, all racial groups do not buy or use or sell drugs at any other different rate than each other. All racial groups are relatively equal when it comes to that. Again, I know it's a misnomer that people assume that African Americans are more likely to sell and use drugs than other groups, but they're not. And therefore, you consider that most people in jail are there because of drug reasons. And you consider the fact that African American men in particular only represent 6% of the population, yet we represent over 50% of the inmate population. That's a pretty huge disparity. Just to give a little perspective, the United States only has 5% of the world's population, but yet we actually have 25% of the world's prisoners. So we think about these oppressive countries around the world like China and Russia and so on and so forth. No one has anything on the United States when it comes to imprisoning people. And again, targeted imprisoning of people, particularly African American men. I went to a conference down in Louisiana, and it was interesting because one of the public health department people were doing a presentation, and she talked about how there was a disparity in maternal death rates when it came to women giving birth, dying from childbirth. And a lot of people like to try to pass it off as, income disparities or some other type of socioeconomic type of reasoning. But the reality is that in this particular case, they did a study and controlled for all those other factors. And the only factor that was left on the table was whether or not a woman got a blood transfusion or not. And so you can't say that, how much money someone makes has anything to do with whether or not they receive a blood transfusion. And despite that, by identifying that, they found that Black women were less likely to get blood transfusions when they needed it and therefore die more often than when given childbirth. There are lots of current statistics and things out there that show that there's disparities between African Americans and other racial groups when it comes to access to care, uninsurance rates, when it comes to how much money we're paying out of pocket for health care, if we're underinsured, or we also lack the number of Black medical providers. One note about that is that lots of studies show that those providers who have more in common with their patients, those patients tend to have better outcomes, whether it be race, religion, gender, sex, whatever it is, those commonalities promotes an increased amount of trust. And so therefore that's to be something to be conscious of. And if on the flip side, it's also be particularly conscious that if you're not of the same sex, race, religion, whatever it may be, is that much more important to to understand those differences and to be aware of those differences and to try to learn as much as you can about what you're not. And because that type of sensitivity literally leads to better health outcomes. All right, so think about this idea of justice. The key is to understand the African American patient. You have to understand African American. There's lots of situations where people kind of see the status of African American health, and then on an individual basis will want to more or less criticize an African American patient versus understanding what are the foundational factors of why the African patient may do or not do things according to plan. Whether it be following their medication regimen or showing up for appointments. What are all the past and current factors that all lead to things not turning out the way it should. And I give you a quick example of how we ought to think a little differently. There's a clinic in Memphis, a pretty large, relatively large clinic, and they were having, have a high minority patient population, but they had a lot of no-shows. And again, if you look at things structurally in our country, we know that the transportation is a problem for lots of people, and if you're low income, you have problems with transportation. It's not a mystery. But instead of penalizing those who could not make it to their appointments, they basically adjusted on their end. They calculated what the typical no-show rate was, and then they basically scheduled appointments and they overbooked as need be so that they had a regular flow of patients, knowing that they're going to have a certain percentage of no-shows. And even if they might have had a day or two here and there where it might have been a little crazier than normal, overall, it was a lot better than trying to just penalize people for not being able to show up to their appointments or be there on time. So the understanding leads to different ways of thinking, and different ways of thinking leads to different making your decisions in different ways, which also leads to providing treatment in different ways, and even how you provide the treatment in different ways. And ultimately, all it translates into is different outcomes. All right, so the present matters as well. Talked about a lot of history, talked about some of the present already. But you got to realize that not only are African Americans trying to recruit from a torrent past of social racism, discrimination, and prejudice in healthcare, but we're also dealing with a legacy of that treatment today. I'll give you one quick example before I give some of the statistics, but there is a study that showed that there's a medical device that was utilized to measure respiratory rates for people, and the device itself actually had a different setting for Black people versus white people. And due to having a different setting, the outcomes end up being different to the tune of it could have been Black people lost about $1 billion in disability payments over the years, and white people would have had $500 million less than what they did get had this machine been calibrated to be the same for all people, whether you're Black or white. And again, and that actually wasn't terribly long ago that those kind of devices were changed and updated and so on and so forth. Again, lots of different statistics I can share about disparities between Blacks and whites and all types of things, whether it be reporting their health status. You got age adjusted rate of cancer deaths. They're higher for Black folks than white folks. And of course, and for mortality. As I mentioned earlier, for mortality, it's such a bad rate for African American women that you talk about having similar rates as in the countries of Peru and Albania. It's 10.8, which ranks 132nd place in the world, right? And so the U.S. Is at 174, which again would be a lot higher if it wasn't for the fact that African Americans were so low. Because you know, Latinx folks, Asian folks have pretty decent infant mortality rates as well. And so it's really the African American infant mortality rate that's so much lower that it brings the average down for the United States. Matter of fact, you look at a lot of the health indicators in the U.S. A lot of times we're the middle to bottom of the rung of industrialized nations when it comes to our health indicators, in part because of our health disparities and our disparities between racial outcomes and so on and so forth. All right, again, lots of other statistics in terms of having coverage gaps in states that have not expanded Medicaid or disproportionately Black. Black people are more likely to white people face barriers to accessing care and experiencing discrimination while seeking care. You got income always plays a factor in overall health and well-being, home ownership rates. When we think about, for example, the social terms of health and how much things like housing and other factors actually play a role in your health and well-being, you think about how all these things matter. Again, when we talk about COVID-19, Black people were 2.5 times as likely as white people to be hospitalized after infection, and Black people were 1.7 times as likely to die than white people when it came to COVID there. Again, the statistics go on and on about the current disparities. There's probably shouldn't be too much of an argument to make that we have disparities in healthcare to this day, gaps in healthcare. You go on and on with those. HIV, hypertension, end-stage renal disease, diabetes, new diabetes. Again, the as I said, hits go on and on and on. So the legacy continues. We got a combination of factors. We got structural racism in healthcare and other areas of life. And we have lingering beliefs and prejudices and discriminatory practices. One of the ways we have to kind of work on these changes of beliefs is thinking about, what are we doing today that makes a difference? And I'll give you an example of how easily it is to not notice it. So when my older brother and I was growing up, one of our favorite TV shows was The Dukes of Hazzard. And Dukes of Hazzard was one of the most popular TV shows at the time, only second only behind Dallas in the late 70s and early 80s. And think about two African American young boys, their favorite TV show is a show that glorifies the Confederate South. Confederate South that, if it had it their way, will still have Black people in slavery. And I can show that historically. There's one guy in particular who in it was 1830 who literally did projections about how many slaves the South would have by 1930. This was a way of life, a way of thinking, enslave people as commodities and a way to enhance the economic power of the country. A matter of fact, some people would argue that the Civil War was fought in large part, again, not just because people want to end slavery, but because if the South became its own country and practiced slavery still while the North didn't, you may have a situation where, to go back to that grocery store example, if the North and South were two separate countries and the South was able to benefit from not paying enslaved people to do all that labor and generate all that revenue, because even during the 1860s, all the millionaires at the time were Southern plantation owners. So you have a situation where the North will become a pretty little brother, little sister to the South over time. And so some people would argue that one of the biggest motivations to keep the country together was the fact that if they were separate, the South would eventually dominate over the North. Again, lack of knowledge can lead to lots of different things. And going back to the Confederate South piece, we are celebrating something that should be completely disavowed. Similar to where in Germany they do a lot of things to acknowledge and really disallow any type of glorification of the Nazi regime, to a point where swastika flags are illegal, unlike the Confederate flags that are waved proudly today. Statues, could you imagine a statue of SS soldiers and Hitler all around, southern part of Germany? Meanwhile, we have a group of people again who wanted to keep African Americans enslaved throughout in perpetuity, having statues celebrating who they were. So there's lots of things like that that we just are not even conscious of, that has has detrimental effects, and it affects everybody. It doesn't matter what race you are. These things are cultural norms that have been persistent, and so we have to constantly try to make ourselves aware of these things because it affects how, in this case, how we deliver medicine. Um, Again, I mentioned earlier some of these things, this lack of knowledge can end up being a lack of empathy and understanding. And generally speaking, we have a broken healthcare system that's built on market principles. I can do a whole semester class on that alone. But just know that because we have a system like that, that is based off of market principles, those who will suffer more in the market are going to suffer more because they don't have that access and ability to pay for healthcare. And then finally, of course, the mistrust. I went through several examples of things that happened over the years that definitely justifies mistrust. So therefore, when thinking about treating patients, we got to realize that mistrust lingers. And if there's nothing to kind of change the story, change the narrative along the way, some cases there's no reason for things to have changed. One quick example, I used to mentor young African American boys, and we had a curriculum, and the curriculum first chapter was how to meet someone, and it talked about you shaking someone's hand and looking them in the eye when you meet someone, and you ask the question, well, why would a mentoring program for Black kids need to have a chapter about how do you meet someone? Well, again, historically speaking, Black people would not only get in trouble, but all kind of things could happen if you had the defiance to look a white person in the eye. And over the generations, this idea of don't you look the white person in the eye, that transfers from generation to generation. And unless there's something to interject somewhere along the way to change that narrative, then things continue to linger on, and so that mistrust and those things do linger. And we got to keep that in mind. So how do we move forward? Well, first of all, we have to care. And when I say that, I know providers care, but we have to care specifically about um, the history that I talked about and the society that we're in and the culture norms that we have to address. We had to care about those things to a degree where we can start looking at things a little differently. The question is, will we go above and beyond? Like for example, do we have a triage mentality when it comes to our health and well-being in healthcare? One quick example I give is that our association that I'm part of, the Illinois Association of Free and Travel Clinics, we instituted a part of our program in our grant distribution process that has clinics looking at what community is most in need in their area. So what population, what demographic, and by and large, as you would guess, that African Americans are generally the most have the biggest healthcare disparities, are the most needed in terms of healthcare. However, a lot of clinics, although they might have been helping minority groups, so on and so forth, might not have been primarily focused on the groups that are most affected. And so by instituting this new plan, we're able to get clinics to be more conscientious of those in their communities who are most hurting when it comes to healthcare and be able to help address that. And also keep in mind that equal still means behind. There's a difference between equality and equity. Equality means that from this point forward, everyone gets treated equal. And again, of course, you can argue whether that's the case even of itself. But even if that was the case, African Americans are started behind. One illustration people give is the game Monopoly. Imagine playing a game Monopoly and the 400 years of oppression and slavery and everything else that African Americans had to endure meant that we weren't even able to get a turn during the first 400 years of the game. And then all that time, then we finally get to start the game. Well, just because we got to start the game 400 years later doesn't mean by any stretch of imagination that we're equal all of a sudden when it comes to what's going on, where we have to catch up. And that's what equity is about. It's not just addressing the inequality, it's addressing inequality that was experienced in the past that needs to be made up for. We also need to be creative. Many people are in environments where resources are limited, time is limited. So we have to be creative in terms of how we change the way we do things in order to account for people's situations. And I know it seems like it's overwhelming and it's too much to handle. But that's why we need to tap into our creativity and find ways to better close these gaps through that means. Also, metrics. We There's lots of discussion in society, even more so now about DEI stuff, but that's a whole nother can of worms. But when people talk about addressing healthcare disparities and trying to do diversity, equity, inclusion things, what I often find interesting is that we don't often have metrics to see where we are to start off with, to have a baseline, and then where we want to get to, and then how we're measuring that ultimately how we're going to get there. For healthcare, we have all types of things that we have strong measurements for. And, you got the, Six Sigma, and, got your black belt and all kinds of Six Sigma and all these quality measures we use and so on and so forth. But when it comes to, diversity in our provider base, diversity in our administrators and board director bases, diversity when it comes to how our literature and things of that nature, there's very few metrics we use to show that we're actually doing things that help close these disparity gaps. And then finally, obviously, there's all kind of once we are creative and we come with the metrics to improve things, then we actually make the actual improvements. And hopefully, there'll be improvements that we can actually see and be able to measure and know that we're actually doing things better than what we've done before. All right. So I threw a lot at you. So I'll leave the floor open for any questions.
Thank you so much, Dr. Trash. That was very great presentation. And we do have a few questions, so I will read those off for you and you can answer them. How do you incorporate a patient's cultural beliefs and practices into their healthcare plan?
Yeah, so I think the first thing is doing a strong assessment, not just of the patient's health history, which we know often do that, which is important, but finding out other types of things about the patient, within whatever comfortability that the patient feels like sharing. But whether it be religious practices, we know, for example, certain religions have a certain way of looking at mental health care, for example, that may not necessarily be conducive to getting proper mental health care. Again, whether we can do something about that particular instance or not, being aware of it is critical. And so finding out something to dig a little deeper when it comes to people's perspective on things. Another question that can help with that is, where do you get your information from? I did a study with vaccine hesitancy among African Americans, and I asked them, where do you get your source of information to determine whether or not you take the vaccine or not? And, so they gave me various answers. And then I said, well, what is about those particular sources that makes you believe them? You know, what is it that gives those sources credibility? And most people couldn't answer that question because you think about it, if you're a researcher, there's this base of foundational, what information comes from this base of foundation research. And even in some of the best research, you have gaps and holes in it in terms of, credibility issues and validity issues and generalizability issues. The best of research has those gaps and holes. So then you pile on top of that, there's bad research out there as well. That's just research that's not done very well at all. And then that's the foundation of information that people get. So then most people's information comes from the next level sources where they just kind of cherry pick some of that research and highlight it. And I give you one example. Someone there was a pretty well-known thought that or belief that getting the COVID vaccine would cause infertility, right? And what happened was that whether it be some type of social media or somewhere, it kind of cherry picked this article. And this article, if we actually go to the source of it, literally said nothing of the sort, right? But because they kind of cherry picked it and put in a headline, and people didn't really go into the depths of reading and understanding it, the mentality of it being causing fertility, transferred to a lot of different people. And I know people personally who didn't get the vaccine because they believe that. So a lot of it is really just listening and asking questions and trying to really learn the patient as much as we can. And again, I know it's difficult because I know time is of the essence. I know you only have so much time to work with when it comes to patients and in our market-driven system. But I would argue to say that to some degree, if you can spend that extra time on the front end and do that discovery and get that much needed and important information, you may save time on the back end and have those better health outcomes and have less needs for visits or even less needs for hospitalizations and so on and so forth.
All right, thank you for that. The next question, how do you identify and address potential cultural biases in your own practice?
Great question. So our group in our clinic, we have a free clinic, started about a little over 20 years ago. We have volunteer providers, nurses, and so on and so forth that provide care. We have a staff, full-time staff that kind of coordinates all our efforts. We do a lot of outreach as well. So for our group, we have regular trainings for our board. Start at the top. Regular trainings for our board and our staff, and then that training transfers down to all of our volunteers. and we try to be ever acquiring knowledge and information about differences. And that our trainings usually help guide us with that, in terms of like how to move forward, how to find more information, how to, change your practices once you do find information. So a lot of it is just having that training put in place, because the reality is that we don't know everything, and there's people out there who study this stuff all the time and do know a lot of these things, and all types of different, cultural competencies and all types of different areas. So solicit those folks. There's also a lot of other resources that's available to learn more. But again, I think the key is raising that consciousness, and as a has as a culture that you're going to constantly want to be an organization that learns. And if you do that, that will translate into better treatment for patients.
Thank you. The next question is, how do we get this information to providers that need it? I feel like a lot of people attending this workshop understand some of this.
Yeah, that's an age-old question when it comes to lots of things related to racial justice and things of that nature. Sometimes you get the same folks who already have this on their heart, attend these kind of things, being more conscientious of it, and so on and so forth. And those who tend not to care as much don't go to these kind of things because they don't care as much. I think one of the key elements to changing that process, a narrative, is through data. So, for example, when it came to surgical checklists, many surgeons, doctors didn't want to use surgical checklists because they thought it was kind of beneath them. But over time, when they started doing research on how effective the surgical checklists were in terms of decreasing mistakes and lowering, things that went wrong during operation after operation, or even shortening recovery times, they found with using surgical checklists. When you get that data, and then you can use that data to share among your providers to show that, hey, this stuff actually makes a difference. And at the end of the day, everyone's in this for better patient care, right? So if you can prove that better patient care is done through these methods, through these studies, regardless of the potential political controversial things people come up with when it comes to race, you have data that shows the healthcare outcomes are better if you do this. And of course, we know again, providers that resemble their patients have better health outcomes because of those similarities and that trust. So therefore, if that's true, even if you're not that group of people, how do you build and develop that trust? Well, you do it by learning more about the patient and understanding the patient better. And so if you can kind of use that data about better outcomes, and then say this is how we can create that by improving our awareness and cultural awareness and so on and so forth, we can have ultimately have better health patient outcomes, and that's what we all want to have, and that probably be the key to that.
Thank you. The next question, how do I reflect on your own cultural background when interacting with patients from different cultures?
Yeah, I'll reference a South Park episode on this one. So there was a South Park episode where one of the kids' dads used the N word on Wheel of Fortune, and throughout the whole episode, that guy's son, who was friends with a black kid, kept saying, "Hey, my dad apologized. He did this. He did this." And he went to his black friend and said, "Is that okay? Is he good now?" And the black kid kept saying, "No, just because you do this doesn't mean you're good." He even went to Jesse Jackson and apologized to Jesse Jackson and so on and so forth. But it's kind of a pretty funny episode. At the end of the day, though, what where the two kids were able to mend their bond was when the white kid went to the black kid and said, "I get it. I don't get it. I get it. I don't get it." And that's what, if we have that mentality, I believe that that's where we can check our own issues at the door. If it's a group of people that we don't identify as, again, whether it be, you know, sex, gender preference, race, religion, whatever it is, if we're not in the same line and with that patient, if we start off with "I get it, I don't get it," and be open to learning and hearing from the other person, despite how different it may be what we're used to, I think that's the first step. And it's a challenge, but I think it could be a fun challenge to navigate where all the things you believe and you have grown up with when it may end up, bumping up against someone else's same set of beliefs, and figuring out how to navigate that to, again, optimize that person's well-being.
Thank you. The next question, how do I adapt my communication style to effectively interact with patients from diverse cultural backgrounds?
Yeah, and that's a loaded thing there. Again, it goes back to just that learning piece. Um, you don't want to be disingenuous with it, right? You don't want to, try to. It's almost like learning just a few words of a language and believing like you get the whole language down. So you don't want to kind of go that direction, if you will. Um, and just know that it just takes time, and that's with anything. Anytime you try to build relationship with people, you try to learn things from people. It is not something that happens overnight. And so, if you want to be able to better communicate with people, again, the key is going to be just learning from that person and observing certain things, and be willing to make mistakes sometimes too. Just knowing that you're not going to do everything perfectly, you're not going to say everything perfectly, and if you have that relationship built and established and that trust established, you can actually work through those things, right? I'm a strong believer that relationships can work through lots of different problems. I give you an extreme case, real story. A guy named Daryl Davis, who's a jazz musician, decided that he wanted to form a relationship with and there's a black jazz musician with a KKK Grand Wizard, right? And so he set up a time to meet with them. The KKK Grand Wizard didn't know it was a black guy he was meeting with. They end up meeting in his hotel room. The KKK member Grand Wizard had his bodyguard there. Things were kind of intense for a while, but they just started talking. And after they talked some more, next thing you know, they talked again. The next thing you know, that the KKK Grand Wizard was coming to Daryl Davis' house for dinners, and Daryl Davis was going to his house for dinners. And this is a TED Talk, by the way, so if you want the references to see it, there's even a clip where Daryl Davis is attending a Klan rally, and this person he developed a relationship with is speaking about how he doesn't trust the people out there, but he trusts Daryl Davis, right? And so if a relationship can translate into Daryl Davis forming a relationship, a black man forming a relationship with a Grand Wizard of KKK, who, by the way, eventually hung up his robe, his KKK robe, and Daryl Davis did this on an ongoing basis, and then over 200 people he developed relationships with hung up their KKK robes. If that can happen through relationship building, then most we can get through most anything with relationship building. So I think that's the key ingredient. Again, I know it's difficult because our healthcare system is not designed to take that kind of time and effort to do that. But again, I think the results will ultimately pay off.
Thank you. The next question is, how do we do this in the current climate when we are essentially getting attacked for diversity, equity, and inclusion?
Excellent question. Um, I believe that as bad as this current climate is on these things, there's actually a silver lining there. And what I mean by that is anytime you're dealing with attacks like this, then there's usually a boomerang effect that happens. And I think it's an opportunity in some ways to raise the consciousness of these issues. If it's being attacked, then there's obviously these strong feelings about it. You ask the question, why is it being attacked? What's the core, what's the underlying reason of why it's being attacked to through this type of ferocity? And that can lend to even more conversations. It can lend to even more people being conscientious of this all of a sudden, that maybe they weren't paying any attention to it, but all of a sudden, since everyone's talking about it and talking about getting rid of it, now it's more of a conversation piece than it was before. And so in some ways you can actually utilize this current environment to take advantage of it and actually raise the consciousness level and the conversation about these kind of things. I find it kind of interesting, for example, how uh, the president talked about providing reparations for white men who've been discriminated against for DEI efforts. And I tell people, well, at least he actually believes in the word reparations if he decided to say white men need reparations. I mean, he believes in the concept of it. And frankly, white men who've been discriminated against from DEI efforts have a much higher burden of proof than black people who've been discriminated against and treated poorly in our society. So if you're if he believes in the concept, he says it, then let's work with that too. So it is a treacherous environment. I don't want to downplay that at all. But I do believe that we can actually have opportunity to take advantage of it as well.
All right, thank you. And the last question is, I'm hesitant to use metrics because it requires effort from many areas, and I don't want poor metrics to mean that diversity, equity, inclusion doesn't work. How do I work around that?
Yeah, I think the key is first of all identifying what is the goal to get you to where you want to be. So, um, the metrics, for example, will be we want to increase diversity on our board, or increase diversity among our staff, or we want to, have get patient surveys back and have people of color have better scores in terms of their experiences at the clinic, or so on and so forth. I mean, these are the kind of metrics that I'm talking about. Very objective type measures that you can use to see if you're making progress in certain areas. Because again, we if we know that certain things translates into better health outcomes, then the metrics should be how do we get to that place of creating that environment where those things exist. And so I know that there's a potential danger to have certain things, have certain metrics, and then you not fulfill those certain metrics and feel like, well, why are we bothering with any of this? But I do think it's important to um, again, measure the outcomes when it comes to the most baseline piece, which is patient care and patient well-being. That's where we want to get to, right? That be improved, and then work your way back from there. And what ways does diversity, cultural competency, cultural awareness, and sensitivity, and what ways do those things translate into these better health outcomes? And so, you're not having like, oh, these kind of useless, meaningless type of numbers that you're tracking just for diversity's sake, but you're really starting off with how do we get to these improved patient outcomes and work your way down from there.
Thank you so much once again, Dr. Trask.